Super. Yeah, so what I'll be talking about is a little bit of a gear shift compared with the two previous webinars, because I'll be talking mostly about epidemiological findings of in relation to vaccines, which may be explained by trained innate immunity. But let me get back to that. First, a little disclaimer here that I usually bring when I present. It's a bit unusual because I start out by telling not only my funding sources, but also mention the fact that I'm mother of 2 kids who received all the vaccines in the Danish vaccination program. And you will understand during this webinar why I'm emphasizing this point, because I will be saying things about vaccines which may sound almost anti-vax to people, because it's so unusual to talk about any potential negative effects of vaccines. But unfortunately, I have to present data which also suggests that this may happen. I also usually disclaim that I've spent part of the last 30 years in Guinea-Bissau, a small country in West Africa, studying the overall health effect of vaccines. And that has made me a co-developer of this concept that I'll be talking about today, namely the non-specific effects of vaccines. So I'm obviously biased in that regard, but apart from that, I don't have other conflicts of interests. According to the current paradigm for vaccines, a vaccine is a biological preparation that improves immunity to a particular disease. You all know that very well. And you probably also know that this is a way of thinking that guides the way we are currently evaluating and monitoring vaccines, because we do that based on the vaccine's effect on the vaccine disease. And also, of course, it's part of the assessment to look for potential plausible adverse events in relation to vaccination. But it's unknown to most people that none of the currently used vaccines were ever tested for their effect on the immune system's ability to handle other infections, because the underlying assumption in this definition of vaccines is that it would not affect the immune system's ability to combat any other pathogen that you vaccinate against one particular pathogen. So in other words, you can basically sit behind a desk anywhere in the world and calculate what would be the overall health effect of vaccines based on this understanding. Because if you know the protective effect against the vaccine disease and you subtract the risk for adverse events that might occur, then you basically, the underlying assumption of the current way of thinking of vaccines is that then you know the overall health effect. So if a measles vaccine, for instance, is almost 100% efficacious as it is, and measles constituted 10% of all death, which was the case when measles vaccine was introduced, then it was the assumption that the introduction of measles vaccine would reduce all-cause mortality by 10%, according to this way of thinking. But our research in Guinea-Bissau has led to a questioning of this current paradigm for vaccines. We have a health and demographic surveillance system in this small country where we follow almost 1/10 of the inhabitants or more than 1/10 of the inhabitants in this small country. And we do that in this country where there's no infrastructure, no registration of citizens, by drawing maps of the areas and by conducting censuses in all the houses, giving the houses numbers, giving each inhabitant of the houses an individual personal identifier, and then following up with regular home visits where we ask, with this particular focus on pregnant women or women of the fertile age and their children, we ask about all kind of health information, and of course also morbidity and mortality. And vaccines we register both at the home visits, but also at the health centers where they're given. Hospitalizations are registered at the National Hospital, which is nearby and has the country's only pediatric ward. And this kind of data has allowed us to do what nobody else really had done before we started doing it in a systematic fashion, namely to look at what is the effect of receiving vaccines as part of the childhood vaccination program on the overall mortality and morbidity, not just the disease-specific mortality and morbidity. And very early on, it became clear that this equation didn't fit what we observed. Because, for instance, the introduction of measles vaccine, which was only supposed to reduce all-cause mortality by around 10%, as I've just explained, was associated with a reduction in all-cause mortality of almost 70%, 70%. And this was seen actually in subsequent studies across 5 different countries where they had data on the mortality before and after the introduction of measles vaccine. Mortality declined in all studies by more than 50%. So much more than explained if measles vaccine only protected against measles death. But in contrast, there were also other vaccines that protected against deadly diseases like diphtheria, like tetanus, like whooping cough, and that still didn't have the anticipated effect on overall mortality. In fact, it looked like some of the children who received these vaccines had higher all-cause mortality than those who didn't receive the vaccines. And since these observations were done in a context where there was a high infectious disease mortality, most of the deaths were due to infectious diseases, then the proposition became that vaccines, in addition to their specific effects against the vaccine disease, also had what we coined non-specific effects on the risk of other diseases, and more particularly on the risk of other infections. And these effects could sometimes be very positive, but they could also, in some situations, or for some vaccines, be negative. There are two major categories of vaccines, and they are the live vaccines and the non-live vaccines. And I guess all of the participants in this webinar know very well the differences with live vaccines containing the attenuated version of the pathogen that leads to a mild disease in the body, usually so mild that you don't feel it, but they leave a broad and long-lasting immunity, but of course also come with the caveat that in some very few recipients who have very severe immunodeficiency, these vaccines may actually cause the real disease. But on the other hand, we have the non-live vaccines. They are, of course, not very alarming to the immune system. And therefore, these are the vaccines that everybody knows because they have to be given in several doses to evoke immunity, and often also together with an adjuvant to really tickle the immune system to respond to these inert substances. These vaccines, of course, have to be given in more doses, but they also come with some advantages, among others, that they can't create the real disease in the host. So more and more vaccines nowadays are non-live vaccines. But the very intriguing finding we have made, or the observation we have, is that these two groups of vaccines differ tremendously when it comes to their non-specific effects, because very consistently we have seen that live vaccines protect against unrelated infections and reduce all-cause mortality and morbidity much more than explained by prevention of the vaccine disease. But the non-live vaccines, in contrast and worryingly, seem to increase the risk of unrelated infections. So the specific protection against the vaccine disease comes at a high price, namely increased risk of other infections and increased all-cause morbidity and mortality. And that particularly is seen in females. So I'm going to bring some examples of these observations. I can't show you all our research during many decades, but I'll give you a few examples of both the beneficial and the harmful non-specific effects. So for the beneficial effects, I would like to talk about Bacille Calmette-Guerin vaccine, a good French vaccine that, of course, was invented by French researchers more than 100 years ago, and that you all probably know very well. This vaccine we had seen in numerous observational studies was associated with great benefits compared with not receiving the vaccine. But of course, there could be some degree of healthy vaccinee bias, that it's the healthy children who are vaccinated. So we were really happy that we had an opportunity to test these observations in randomized trials, because there was one particular group of children that didn't get BCG at birth, which is otherwise normally the recommendation in TB endemic areas. And this was the group of children with low birth weight, because they were believed to be too immature. So it was recommended to delay their vaccine until the first DTP vaccine around 6 weeks of age. So this gave us the opportunity, and we also got ethics support for that based on the data, to randomize these low-weight neonates to get either the normal treatment of all polio vaccine at birth and the delayed BCG vaccine, or the intervention group that got BCG already at birth with all polio vaccine. So we had a window in the neonatal period where we could compare in an unbiased fashion children who did get or didn't get BCG vaccine. And here are the results of 3 randomized trials where BCG was given at birth or later. And you can see the black columns are the BCG early group, the children who were randomized to get BCG at birth. The gray bars, those that got it later. And you can see that across 3 trials with 3 different underlying mortality levels in the control group, we saw considerable reductions in neonatal mortality associated with getting BCG early. And in a combined analysis of these 3 trials, BCG was associated with a 38 highly significant reduction in all-cause neonatal mortality, which was of course not due to the protection against tuberculosis, because tuberculosis doesn't kill children in the first month of life. This was mainly due to non-specific protection against septicemia and respiratory infections. So very clear indications here that BCG vaccine against tuberculosis could induce some kind of immunostimulatory effect that would protect the babies that received it against unrelated infectious diseases. In 2014, WHO conducted a review of the non-specific effects of vaccines, and it was published in BMJ in 2016. And they looked at BCG, DTP, and measles-containing vaccines. And as you can see here, for BCG vaccine, also concluded that BCG seemed to reduce overall mortality by more than expected. And in a meta-analysis of the 5 randomized trials that were part of this assessment and 9 observational studies, BCG was associated with a almost 50% reduction in all-cause child mortality. I guess you're familiar with these estimates here, but this is the ratio of mortality between BCG vaccinated and BCG unvaccinated children. That is 0.53, suggesting a 47% reduction in mortality in the BCG vaccinated children. There'll be many more of these estimates in my presentation. After the BMJ review, or the WHO review of the BMJ paper, there was another randomized trial being done in Uganda. Here, they actually randomized both low birth weight and normal birth weight children to BCG or no BCG, and followed them up to 6 weeks, where the delayed group received BCG. And you can see here by Prentice et al., published in Lancet Infectious Diseases in 2021, that BCG was associated with a 29% reduction in the non-TB infectious diseases up to 6 weeks of age when the controls got their BCG vaccine. So a confirmation here from another part of Africa. And most recently here, just a few months ago, another confirmation from Guinea-Bissau, from our setting, where we did a cluster randomized trial, randomizing children. They all received the WHO recommended home visit within 72 hours of birth. It's not implemented in Guinea-Bissau, but we implemented it for the purpose of this trial. And WHO doesn't recommend that children should receive vaccines at these visits, but we randomized children to get the vaccines with the visit or not get the vaccines with the visit. So all children again received the visit, and half of them, half of the clusters received BCG and OPV. The other half didn't receive any vaccines with the visit. And you can see here that we had a tremendous effect of receiving both these 2 live vaccines at birth versus not receiving them, with an almost 60% reduction in the risk of non-accident mortality up to 6 weeks of age observed. So how come that a vaccine against tuberculosis can protect children, apparently protect children against dying from all kind of reasons, for all kind of reasons? Well, that seemed absolutely biologically implausible to many people, and therefore there was also a long period where these findings were dismissed. And you can see here from February 2012, a letter to the editor based on the publication of our second trial from Guinea-Bissau of BCG having these tremendous effects by esteemed professors at London School of Hygiene and Tropical Medicine. And they state that this is unlikely that there would be an immunological mechanism that could explain such a rapid impact on mortality. And there we've just been extremely fortunate to that there are clever immunologists who have been looking for and found immunological mechanisms that could explain these effects, or actually coincidentally found immunological mechanisms that could explain these effects. Because I think most of you are aware of Mihaly Tea's work and the groundbreaking paper that came out in PNAS in October 2012, showing that BCG could induce epigenetic modification of the monocytes, leading to increased non-specific protection against other pathogens. So I usually present this when I'm presenting to students, and I say we should never forget that with Asimov, that today's science fiction is tomorrow's science fact. What seemed biologically implausible, and in my view, one should never use biologically implausibility to dismiss any epidemiological finding, because I think this is a proof of concept that well, we might not have found the immunological mechanism yet, but it may very well exist, because of course this epigenetic modification of the monocyte would indeed be able to explain what the professors didn't understand just a half a year before, namely that a vaccine could have this very rapidly occurring effect on all-cause mortality. We have done a lot of work. We've been fortunate to work with Mihaly on a lot of different projects, and I think this paper is one of the most important ones in my view, because it shows not only in vitro but also in vivo the impact of receiving BCG on an unrelated pathogen. In this experiment, we took Dutch medical students and randomized them to BCG or to saline, and 4 weeks later we challenged them with a yellow fever vaccine, which produces viremia around day 5. And what we saw was that indeed there was viremia in those who had received saline, but it was much reduced in those who had received BCG 4 weeks before, and this was due to epigenetic modifications that led not least to to more IL-1 beta production in the BCG vaccine recipients. So this, of course, is completely rewriting the understanding of vaccines, that the fact that a bacterial vaccine can affect the response to a viral challenge down the road. This shouldn't be happening according to textbooks, but it indeed does seem to happen. So what we have learned from BCG is that BCG has effects that cannot be explained by prevention of tuberculosis, namely these tremendous reductions in all-cause mortality. And we've seen from immunological studies that this may be explained by trained immunity. And then I should also mention that actually there is another immunological mechanism that may explain some of the huge effects on neonatal septicemia, namely what we published together with Brooke et al. In 2020, that BCG also seems to induce an emergency granulopoiesis in the bone marrow, leading to more granulocytes being let into circulation, and that could help explain also in animal models a strong effect on septicemia. But of course, you also know the flip side of trained immunity, and that is tolerance. And that I'll devote the second example to, a second example of non-specific effects. Because as I mentioned at the beginning, some vaccines could be protective against the vaccine disease, but still overall harmful. And the most well-known example is the high-titer measles vaccine, which was introduced by WHO in low-income settings in 1989. It had the great advantage that it could be given already at 4 to 6 months of age in the presence of maternal antibody and still be fully protective against measles infection. So basically, this seemed extremely promising, that you could protect children against measles earlier. And due to the understanding, the perception of vaccines, this was only studied, the high-titer measles vaccine was only studied for its effect on antibodies and on clinical measles. There was no assessment of the effect on overall health. But independent researchers, among others, Peter Arby from our group, did randomized trials and tested the high-titer measles vaccine at 4 to 6 months versus the standard measles vaccine that was given at 9 months. And out of that came in the first place, 2 studies that were later corroborated elsewhere, but which showed uniformly that for boys in blue, it didn't make any difference whether they received the standard titer, the measles vaccine, the control, or the high-titer measles vaccine, the EZ measles vaccine. But for girls, it made a world of a difference, because the control girls had almost the same mortality as the control boys and the EZ boys, but the girls who received the high-titer measles vaccine had higher mortality than any other group. And this was seen in Bissau, in Senegal, and later also in Sudan and Haiti. And in 1992, WHO then decided to withdraw the measles vaccine, the high-titer measles vaccine, which, according to numbers, had it not been stopped, would have led to around 500,000 additional deaths per year. So these effects are not trivial in a setting with high infectious disease mortality. But unfortunately, nothing was really done to understand why a vaccine could have such negative and non-specific and sex differential effects as these findings allude to. So let me move to another vaccine here, namely the DTP vaccine, because you may have noted when I showed you this slide of the WHO review from BMJ 2016, that while BCG and measles vaccine were associated with huge reductions in all-cause mortality, namely around a halving of all-cause mortality. Then DTP vaccine, on the other hand, the diphtheria, tetanus, pertussis vaccine, which protect against 3 deadly diseases, was associated with a tendency for increased mortality. The reviewers put some emphasis on the fact that the result was not statistically significant, but what is very highly statistically significant is, of course, the difference in effect between the 2 live vaccines on one hand and the DTP vaccine on the other hand. There's simply no bias that can explain why sometimes even in the same populations, the vaccine should have such different effects on all-cause mortality. After the WHO review, another 2 studies were published. These are marked in red here, and you can see that they corroborate the findings, and there is now a highly significantly increased mortality associated with DTP vaccine, as you can see in the meta-analysis, the meta-estimate here, which is a meta-estimate of all the studies which have been done comparing DTP versus no DTP with prospective follow-up and published by us a few years back. And as I mentioned, this is particularly seen in the females. So here are the studies where DTP versus no DTP could be compared in females only. And you can see that in females only, it's a full 2.5-fold higher mortality associated with DTP vaccine. And this, based on the data we have, is due to increased susceptibility to other infections. So DTP, again, protects against diphtheria and tetanus, pertussis, but seems to increase the susceptibility to other infections that then kill the children. We are also closer to understanding the immunological mechanisms here, because together with Mihai, we also did a study in 75 females that were randomized to DTP, to BCG, or both, and those who received either BCG or DTP crossed over after 3 months. And we didn't use the exact DTP, the wholesale pertussis. We used a TDAP, the diphtheria, tetanus, acellular pertussis vaccine, which was approved in the Netherlands. But we concluded that this vaccine in these females led to long-term repression of monocyte-derived cytokine responses, and actually also both to long and short-term repression of T-cell reactivity to unrelated pathogens. So we seem to have an immunological mechanism here, which may help explain why DTP could at the same time protect against deadly diseases, but also increase susceptibility and mortality from other infections. Actually, it turned out that DTP vaccine was the reason for the higher mortality after high-titer measles vaccine. Because when we started seeing the negative effect of DTP vaccine, it gave the idea to reassess the reasons for the high female mortality, because high-titer measles vaccine had been given so early that many children received DTP vaccine after high-titer measles vaccine, which was not the case for the standard titer measles vaccine. By the time of 9 months, most children would have received all their DTP vaccines. So in a reanalysis of the original trials, it became clear that the higher female mortality after high-titer measles vaccine was actually due to the fact that it was only seen in those who got DTP vaccine or inactivated polio vaccine after high-titer measles vaccine. So it was due to the fact that high-titer measles vaccine changed the sequence of vaccinations. So children ended up having a non-live vaccine as the most recent vaccine. So DTP was the real culprit, but it also is a finding that emphasizes strongly that the sequence and combination of vaccines matter a lot. And it's the most recent vaccine that has the strongest effect on the immune system. This increased female mortality after non-live vaccine, we've seen now for 6 non-live vaccines, namely here as presented in the table, DTP vaccine, RTS malaria vaccine, inactivated polio vaccine, hepatitis B vaccine, pentavalent vaccine, and H1N1 influenza vaccine. Throughout this, here on the first column, you can see the combined relative risk of all-cause mortality in vaccinated versus unvaccinated. In the second column, you have the same estimates, but just for females. And in the third column, you have among vaccinated children, the ratio of mortality among girls versus boys. And you can see consistently that all the vaccines are associated with higher mortality in all children. This is due to a particularly high mortality in females. And you can see that among vaccinated children, females consistently have higher mortality than males. And this is not the case when you look at children who have a live vaccine as their most recent vaccine. Then girls tend to have lower mortality than boys. So this has nothing to do with sex preferential treatment or anything. This is really a very strange phenomenon that didn't occur either in the pre-vaccination era. It's highly suggestive of biology of vaccines being the main explanation for this sudden increase in female over male mortality. So what we learned from studying high-titer measles vaccine and DTP vaccine is that a protective vaccine can have negative and sex differential non-specific effects that actually makes it worse to get the vaccine than to not get it. So what I've shown you here are just a few examples of non-specific effects of vaccines, and the observation, the overriding observation that live vaccines have beneficial non-specific effects, but non-live vaccines have harmful non-specific effects. And I've also emphasized the point that this is particularly seen as long as a given vaccine is the most recent vaccine. And what we have concluded is that the effects are seen for at least 6 months or until the next vaccine is given. We are quite far in terms of getting this more broadly recognized among researchers, I think. So we published a paper in 2020 where we proposed that it's time to change the paradigm for vaccines. And shortly after, Nature put the discovery of beneficial non-specific effects on their list of major milestones in vaccines. And the latest edition of Plotkin's Vaccines, which is the greatest textbook in vaccinology, the 8th edition from 2022, actually has a whole chapter 3 on non-specific effects of vaccines. But it's still complicated to get these findings pushed out into policy. And I think that is because there are some big hurdles to fight there. But I just want to spend just a few minutes on talking about the many implications of non-specific effects of vaccines, because they are not only conceptual, but they're also practical. And again, I'll dwell on the practical in the last part of the talk. But for the conceptual implications, it's of course clear that these findings call for a revised understanding of the immune system and a focus on optimizing immune fitness rather than combating single diseases. I also usually say to people, we should never talk about vaccines in plural. They're super different, both in terms of specific and non-specific benefits, and we should talk about them one by one. Another very important conceptual implication is that because the non-specific effects work on the innate immune system, they are very context dependent. They depend on other factors influencing the innate immune system and the immune system in general. So in contrast to the specific effects of vaccines, which we usually think of as pretty context independent, well, we know that females make more antibodies than males, and elderly make less antibodies than younger people, but generally speaking, we count on almost everybody to respond with a specific immune response and specific memory towards a vaccine. Then we cannot always predict the effect of the non-specific effects of vaccines and their magnitude, because they are modified by other factors. They're context dependent. But again, I'll dwell on the practical implications, which are both for the vaccination programmers and also for our framework for testing, approving, and regulating vaccines. If we start with the vaccination schedule, they are quite different all over the world, and even in high-income settings, we have quite different vaccination programs. So here I've just shown you for an example, the vaccination program in Denmark, which is my home country, and in the US. And I've marked all the vaccine sessions where you get a non-live vaccine with red, all the sessions where you get a live vaccine with green, and all the sessions where you get both with yellow. And you can see that the Danish program is very conservative compared with the US program, but you can also see that children actually spend most of their first 5 years of life and most of their childhood in general having a live vaccine, namely MMR, as a single dose, single vaccine, as their most recent vaccine. Whereas in the US, there's almost no sessions where you would get a live vaccine only. So children get many more vaccines, and they also spend much more time with a live and non-live, or a combination of live and non-live, as the most recent vaccine. And it may actually matter for overall health, because here is a study from CDC covering more than 300,000 children from 2005 to 2014 and comparing the risk of hospitalization for non-targeted infections. So fortunately here we are not talking about mortality, but just hospitalization for non-targeted infections. That shouldn't be affected whatsoever whether you receive a live, non-live, or both But what they saw in this study was that receiving a live vaccine alone compared with inactivated non-live vaccine alone was associated with a 50% reduction in the risk of getting hospitalized for non-targeted infections, whereas concurrent live and inactivated vaccines compared with non-live vaccines was associated with a 22% reduction. So you can see that this suggests a hierarchy here where the lowest risk of getting hospitalized for non-targeted infections is among the children who received a live vaccine as their most recent vaccine. Then comes a mixture, and then comes non-live vaccines alone as the worst solution. So if we take these results for granted, then it really suggests that much could be gained by changing vaccination programs to emphasize having live vaccines only as the most recent vaccine for the largest part of childhood where you have most infections. It also suggests to policymakers that it might be interesting to look into whether there are versions of a given vaccine that are both live and non-live. So here's a very recent study from China where they looked at the non-specific effects of live attenuated Japanese encephalitis vaccine versus the non-live version of the same vaccine. And what they saw here, you have JEI and JEL for inactivated and live, was that there was a much lower risk of getting lower respiratory tract infections in general if you had received the live vaccine versus the non-live vaccine. And you can also see here that parallel to what we see in other studies, the effect was strongest for females. So females benefited most from getting the live version of the vaccine versus the inactivated vaccine version of the same vaccine. So maybe there is something to be gained here if we have vaccines that come in two versions. And there I know Camille Locke, for instance, from France is working on this live pertussis vaccine. I have great expectations for that vaccine because it may actually be a way to give this protection against pertussis in a live version that could confer also non-specific benefits in contrast to what we fear is the case for the non-live version of the pertussis vaccine. And just because you're an immunologist, I threw in this paper that is the only example I have of studies we have done where we compared the live and non-live version of the same vaccine. Also, again, with Mihaly Tea's group, looking at the old live smallpox vaccine that induced in our studies innate immune training. But when we looked at the new modified version, the Vaccinia ankara, modified Vaccinia ankara that has been modified to lose many of the live properties, then we saw that compared with RPMI, it induced tolerance and didn't induce the same training as was seen with beta glucan. So really the immunology parallels the epidemiological findings that you get innate immune training from the live versions of the vaccines, you get tolerance and potentially increased risk of other infections from the non-live versions of the vaccines. I'll move on to talk about the implications of these findings for the system or the framework for testing, approving, and regulating vaccines, because last year we published a paper saying if non-specific effects are real, then we have some great omissions in the current system for testing vaccines. The current phase 3 trials do not focus on the risk of all-cause mortality and morbidity. That some of them use another vaccine as a placebo vaccine, but of course, if you believe in non-specific effects of vaccines, such another vaccine could have non-specific effects, and so you don't really know what you're comparing with. And of course, all symptoms from a perspective of non-specific effects could be due to the vaccine and should be recorded for the full duration of any phase 3 trial. And not least for the post-marketing period, I find it highly problematic from my perspective that we only rely on observational comparisons of vaccinated and unvaccinated participants and before-after comparisons, rather than doing what seems to be the only obvious smart thing to do, namely to make sure that also post-marketing we do large-scale studies, ideally randomized trials, but at least stepwise rollouts that allow us to do a follow-up for all-cause mortality and morbidity among participants to be sure that any vaccine, how promising it may seem to protect against the vaccine disease, doesn't have negative non-specific effects. And of course, also to find out if it has beneficial non-specific effects, which would make it even more valuable and more recommendable to parents and recipients in general. We went back to the phase 3 trials of COVID-19 vaccines because they had, as you know, not been tested for their non-specific effects. The best proxy we could find was to look for all-cause mortality in the phase 3 trials. And none of the single phase 3 trials were big enough to study mortality. All of them reported mortality as they have to do. All of them also concluded that none of the deaths were related to the vaccine, which is normally what vaccine producers tend to report. Anyway, the deaths don't lie, so to speak. So we just counted the deaths in the each of the trials that were done with mRNA vaccines on one hand and with adenovirus vaccines on the other hand. And we compared the risk of dying in the vaccinated versus the placebo recipient within each group of vaccines. And you can see the results here. They took quite a while to get published, but they are published now in iScience in 2023. And they show quite consistently that adenovirus vaccines are associated with huge benefits on overall mortality, which are to some extent explained by a very beneficial effect against COVID-19 death. But there was also an independent, significantly beneficial effect on cardiovascular death. And generally speaking, in the lowest part of the forest plot here, where we look at non-accident, non-COVID death, the ones that we could assume would be non-specific or modifiable by non-specific effects of vaccines, then we see that the adenovirus vector vaccines are associated with a 62% significant reduction in all-cause mortality. And in contrast, you see that there's no such effect of mRNA vaccines. The trials were small. You find the anticipated tendency for a beneficial effect against COVID-19 death. It was not significant, but of course, probably have been if the trial had been bigger. But you can see that this is counterbalanced by increased risk of dying from other causes, or tendency for increased risk of dying for other causes. So all-cause mortality is not affected by receiving COVID-19 vaccines. And you can see that the effect of mRNA vaccines and adenovirus vector vaccines are highly significantly different when we look at overall mortality and non-accident, non-COVID death. So adenovirus vector vaccines seem to behave like live vaccines, which is actually perhaps not surprising given that they are built on a live adenovirus vector. We have been criticized a lot for numbers being small, but we do think that the overriding problem here really is that the vaccines were not tested for overall mortality effect before being rolled out. So the small numbers is a problem of the system, and that is something that should be corrected. It's not a problem of our analysis. Or it's also a problem of our analysis, but it's simply not good enough that we are vaccinating billions of people with vaccines where this is the best data that is available currently about their effect on overall mortality, because none of the data that has been produced post-rollout are randomized and placebo-controlled. When we looked at the children, or we also looked at the children and did a similar reanalysis of the phase 3 trials, then this is in preprint. We have found that both, there were no adenovirus vector vaccines given, but just mRNA vaccines. But we looked separately at Pfizer and Moderna vaccines, and we found similar signals when we looked at the risk of non-targeted infections, namely lower respiratory tract infections. We could see that here for lower respiratory tract infections on left, and for RSV, which is part of the lower respiratory tract infections, but for them independently, both vaccine types were associated with an increased risk of getting these two outcomes. So you can say here what this suggests is that the mRNA vaccines to children may have given them protection against COVID-19, which is not generally a severe disease in childhood, but it seems to have come with the price of an increased risk of lower respiratory tract infection and also of RSV infection, which are both more severe vaccine types in children. So this worryingly suggests and corroborates what we saw in the adults, that epidemiologically speaking, the mRNA vaccines do not confer overall benefit to the recipients. And here also we looked into what other people have published in regard to their immunological effects. And here are the results in adults, a study from Mihaly Tea's group, where they found in a before-after study of vaccinated adults with mRNA vaccines that there was long-term effects on both adaptive and innate immune responses. And here particularly you can see to viral ligands, interferon gamma responses decrease with increasing number of doses of vaccines. And in children, Nigel Curtis' group looked at children before and after mRNA vaccine. and saw that the innate immune response to viral and bacterial stimuli was decreased compared with pre-vaccination. And after 6 months, this was still sustained for the responses to viral stimulants. So this is really corroborating the immunological findings from the adults. And what it does suggest to me is that the mRNA vaccines behave like non-live vaccines. They seem to induce tolerance towards not least viral ligands. And this may help explain why we see the increased risk of lower respiratory tract infections and RSV in children who receive mRNA vaccines, and why we don't see any overall mortality benefit in adults who received mRNA vaccines. The vaccine I started with, I will also end with, because interestingly, from our perspective, a lot of groups started looking at BCG vaccine as a tool to combat COVID-19 during the pandemic. A total of 11 trials have been done now that had mortality occurring within the 6 to 12 months of follow-up. And we have, just as we do for any other vaccine, we simply accumulated the death reported in each of these trials and done a combined analysis. And you can see that across the trials that were done both in elderly and in healthcare workers, there's lower mortality in the recipients who received BCG vaccine versus those randomized to placebo. And in a combined analysis of all the 11 trials, receiving BCG versus placebo was associated with a 43% reduction in all-cause mortality during the following 6 to 12 months of follow-up. So you can just imagine if this is actually true, if BCG vaccine also in adults and elderly can induce non-specific benefits that just within such a short period of follow-up could actually have dramatic effects on all-cause mortality, then we might have a really nice weapon at hand, both for future pandemic situations, but perhaps also in peacetime to strengthen the immune systems of elderly. So with that, I just want to say thank you for the invitation once again. It's been a pleasure to present for you, and I'm absolutely happy to take any questions you may have.
Thanks, thanks a lot, Christine. It's like amazing to see like the data. You have a lot of questions that arise from your presentation. So I try to take them all. One question is regarding the potential interference between vaccines. But I think you mentioned it in one of your slides with a kind of hierarchy between live vaccine alone and a mixture of live vaccines together with inactivated vaccine compared to inactivated vaccines alone. What do we know? I remember some study analyzing the effect of DTP mixed or not with a live vaccine. What do we know about the interference and the mechanisms behind?
Yeah, thank you. So we know that as shown in the US study, the live vaccines are better than the mixture, are better than the non-live. So the mixture of vaccines behave kind of in between. We have seen that both in the transition going from BCG to DTP, where those who get BCG with or after DTP, they do better than those who have DTP as their most recent vaccine. And we also see it in this in the subsequent transition from measles vaccine. If you get DTP vaccine after measles, with or after measles vaccine, it's worse than to have measles vaccine as your most recent vaccine. So we see this consistently over the different transitions in the vaccination program. And we are fortunate there that in some situations it's the compliant children who get one, and in other situations it's the compliant children who get the other. So in that sense, we are pretty sure that this is not just caused by bias, but it does suggest some very interesting programmatic issues. For instance, in Denmark, we give MMR vaccine at 4 years of age, and we give DT booster at 5 years of age, and there's really no good reason why it should be that way. I really would like to do a study where we just swapped around and in a randomized trial and looked how it went with overall hospitalization risk for children, whether they got one or the other. From the specific point of view, it shouldn't matter. From the non-specific point of view, it may well make a difference for the children.
Yeah. And regarding mechanisms, do we know whether epigenetic imprints might be erased by the new vaccine?
Yes, this is
of
indeed,
course, it's like the effect is so everything is dynamic, and so that's how to model it actually.
Yeah, and we don't know that much, but in the study I alluded to where we did BCG, DTP, or both, and then did a crossover study, it indeed seemed that those who got DTP first and then got BCG, that they regained the innate immune training and lost the tolerance induced by DTP once they got BCG. So it seems to be related to epigenetic mechanism, and in that way, I think that that it is related to the innate training and the fact that a new vaccine can erase and methylate or demethylate where the other vaccine had done the opposite.
And another question from the chat was about the all-cause mortality or the beneficial versus deleterious effect. For instance, for the DTP measles vaccination, whether you could see a difference of effect on bacterial versus viral or other disease origin. Is it fully non-specific or a bit non-specific, the effect, in another word?
Yeah, in most studies, I mean, for instance, with measles, there we can mostly exclude measles deaths because they're so easy to diagnose. In other situations, we cannot be sure. And generally speaking, we haven't done a lot of pathogen-specific studies because that, of course, implies if you start measuring which pathogen the child is infected with, then you also treat it, and it doesn't lead to death. So we rely to a large extent on verbal autopsies. The big categories that we see are affected are primarily the respiratory infections and then septicemia for the babies, whereas we see little effect on death due to diarrhea. But we cannot get more pathogen specific, unfortunately.
Okay, thanks. People also wonder whether there are differences between BCG strains and what could be the link between the non-specific effect and the attenuation versus virulence of BCG. And from this, I jump to another questions regarding adjuvant. Do we think that adjuvant could compensate and mimic the effect of live attenuated vaccine if added to inactivated vaccines, basically?
Yeah, so BCG strain is indeed a big difference. So Calmette Galrang, they in the old days, they sent their vaccine to all different countries, and the different countries started to do their own vaccine production, and the strains changed along the road. So there are many studies that show differences both at the immunological level, at the innate immune training level, at the TB specific level of the different strains of BCG. And we also think that we see differences epidemiologically speaking. There was a trial in India being done in 2 different settings where they used the BCG Russia strain, and they didn't find an effect on neonatal mortality. These trials were also different in the sense that they were done among children with a very low birth weight and with very high degree of birth defects and birth related mortality. So very little of their mortality was due to infections. So perhaps it was also optimistic to expect BCG to change that. But under all circumstances, we do think that the BCG Russia may also have less beneficial non-specific effects. And so but probably the vaccine strain can also be too strong and the dose can be too strong, but this is all things that need to be explored in more detail. So the important thing is one should never, just as one shouldn't talk about vaccines in plural, one shouldn't talk about BCG. It's always important to say which kind of BCG one has used for a given study and to be aware that there can be differences. I think a lot of people are interested, among others, Mihai Netea, in can we mimic these effects of the live vaccines? Could we actually give some kind of immune boosting vaccine with different, using different adjuvants or components that don't necessarily imply giving a live bacteria? I don't know, to be honest. I'm a little bit in doubt whether we can ever mimic anything that seems to work so beautifully. Yeah.
You're right. Regarding this effect of BCG strains and the effect of dose also, as you highlighted with the measles vaccine, some of the participants of the webinar are wondering whether the self-amplifying mRNA might look or behave more like a live vaccines as compared to the mRNA vaccines that we got against COVID. Is it a question of replication or maybe like a longer stimulation of your immune system to get a beneficial non-specific effect?
Yeah, I really wonder about this part about replication, because what we saw for the smallpox vaccine study that I showed you, the immunological study comparing the old live smallpox vaccine versus the modified Vaccinia ankara, one of the main changes in the modified Vaccinia ankara is that they have that the vaccine doesn't replicate anymore. And in that study, it seemed to lead to tolerance, but the adenovirus vectored vaccines were also non-replicating adenovirus. So I'm really not sure. I think we have results pointing in both directions, whether replication in itself is necessary and sufficient or not. I cannot get closer to that right now.
We still need to decipher the mechanisms,
yeah.
I guess. And somebody also pointed out the effect of macrobiota. Do you have any comment on the interactions between vaccines, microbiota, and antigen-specific and non-specific effects? Do you think that it's like a key player in your equation?
I suspect it is. We have not much data on it, but we see for oral polio vaccine modifications, and that's perhaps not so surprising. It's given orally, it colonizes the gut, that it leads also to changes in the gut microbiota. And with the whole gut-lung microbiota crosstalk, I mean, some of the particular beneficial effects we see on the respiratory infections may be related to such changes. But again, I'm an epidemiologist. I apologize for not being able to give very detailed answers here, but I hope some immunologists will be curious to test it, because we need these kind of studies to address and to answer the questions.